Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club podcast. Welcome to this special melanoma update with Craig Underhill and Georgina Long. Georgina is a world-renowned Australian researcher. Her passion for her specialty shines through in this thorough interview. Whilst melanoma rates in older patients are improving, young Australians are now more likely to be diagnosed with melanoma than any other cancer. It's also set to be the number 2 cancer in the United States by 2050. Despite these sobering stats, the advances in this specialty in the last few years have been nothing short of phenomenal. And these advances are also relevant to other tumour types, so I hope you will find value in this absolutely fascinating interview. Thank you, Craig and Georgina. As ever, you'll find links to all of the papers discussed, bios and Twitter handles in the notes on our website. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology Podcast.
So it's a great pleasure to welcome back Professor Georgina Long, who's the Co-Medical Director at the Melanoma Institute in Sydney, Professor at the University of Sydney and Royal North Shore Hospital. So welcome back, Georgina.
Thanks, Craig. It's great to be chatting about cancer with you again.
Yeah, thank you. Yeah, we were talking before we started recording about melanoma sort of seems to be, despite its prevalence, it seems to be overlooked a little bit on the post-ASCO sessions, like we have breast cancer and GI and GU. But, it's actually what's the 4th most common cancer in Australia.
Actually, it's the most common cancer in young people. Overall, for men aged 25 to 40 and for women aged 15 to 30-something. So it's actually the most common cancer overall in our young people, just as an aside.
Yeah, we mentioned in the podcast recently a paper that was in JAMA in April, estimated projection of US cancer incidence and death to 2040. And I was really surprised to read that melanoma was going to become the 2nd most common cancer in the US in 2040, behind breast cancer in front of lung. So that was a bit of a surprise to read that. So is that driven by lifestyle reasons, Georgina?
Yeah, it's a good question. It's multifactorial. Certainly lifestyle has completely changed the melanoma incidence throughout the sort of 70s, 80s and 90s in Australia anyway and around the world. In our country, Australia, we recognise it. We're very educated about melanoma. But the other factors that go into the rising incidence is the ageing population. Melanoma is very common in the old, even though it's the most common cancer in young people. Young people don't get cancer, as we all know, not as much as old people. So it is multifactorial, but definitely lifestyle has absolutely made it a 20th century cancer. And hopefully by mid-21st century, we can turn that peak around and eradicate it. That's our goal.
Wow, it's a little bit like smoking. So we've maybe post the peak. So
for Australia, yes. For Australia, the incidence has slowed and is starting to decline. Even though it rises each year, it's rising by less. New Zealand's not far behind us, but the US is the most behind in terms of peaking and then falling.
Yeah, wow.
Yeah.
So good reason why everyone needs to know a little bit about melanoma. And plus, I think it's kind of like the poster child for rational development and science-driven development, new paradigm. So we've seen...
Couldn't agree with you more. And couldn't agree that there wasn't enough. There's never enough on melanoma at any conference.
Right. So let's get into it. So what was new at ASCO?
I think the biggest news was the first phase 3 trial of a new checkpoint inhibitor. So this is across oncology. Like we were the first, when I say we, I talk about all of us in the world working in melanoma with anti-CTLA-4. We were the first with checkpoint inhibitors that were effective, or immunotherapies that were effective, like really effective. And now we've got a third drug on the block, checkpoint inhibitor, and that's the anti-LAG-3. There are many companies who are developing anti-LAG-3 molecules. This is the one called relatlimab, and it was combined with nivolumab in a phase 3 trial. So in that trial, patients were randomized first-line advanced melanoma to either nivolumab or nivolumab combined with relatlimab, which is the LAG-3. So anti-PD-1 combined with anti-LAG-3. Saw a significant improvement in progression-free survival in this randomized phase 3 trial. In fact, the hazard ratio was 0.75 for progression-free survival, p-value 0.0055. So that's pretty amazing when the bar is so high in melanoma. The 1-year progression-free survival landmark. Now, as you know, with immunotherapies and in melanoma, we much prefer to talk about either hazard ratios and landmarks rather than medians. Because of those shapes of those Kaplan-Meier curves for progression-free survival, the medians cannot really give you a good sense of the activity of the drug in terms of quality of life and real improvement in survival. So we like to use landmarks and the hazard ratio. So nice hazard ratio, 25% reduction in risk of progression, and 12-month or 1-year progression-free survival landmark, 48% for the combination and 36% for nivolumab. Now, just as an aside, that Nivo arm, single agent arm, didn't perform as well as we expected. In our initial phase 3 trials back in 2013 of nivolumab versus nivolumab combined with ipilimumab versus ipilimumab, the landmark 12-month was 42% for nivolumab. So this arm didn't perform as well. We haven't worked out why, but regardless, it's a randomized study. Patients were randomized, and we see a 25% reduction in the relapse-free survival risk of relapse. So we don't have the response rate yet. Now, this is one of these curious features of this trial in that in the plan, I was on the steering committee for this trial, in the pre-statistical plan before we started the trial, it was always planned that we would present the response rate when we did the analysis for overall survival. Now, the reason being is that the trial was a phase 2, had an interim analysis, then went to phase 3, which means you have 2 groups of patients, and you can see it in the censoring on the curves. You have your first initial bunch of patients, and then your last bunch of 400, then 300 patients, basically. So to get the proper response rate from that last bunch, because you can get the hazard ratio between the PFS, we have to wait a little longer. So we don't yet have the response rate, a mature response rate presented yet. And that was in the plan. There's been a lot of comment about that, but that's just the way it is at the moment. So we'll wait. Hopefully towards the end of 2021, we will see that.
For the benefit of the listeners, so LAG-3 is an inhibitory signal for the T, like CTLA-4 PD-1. So this is in effect a study where 2 receptors are inhibited. Is that correct?
Absolutely. So you'd all be familiar with checkpoint inhibitors, the way that these immune therapies, and we're working on others, but these immune therapies work on the T cell. The T cell is blind to the tumor, and that's because of the handshake between PD-1 and PD-L1 on the tumor. So we know that mechanism. LAG-3 is similar. LAG-3 has a handshake with the tumor, but it also has a handshake with antigen-presenting cells. So anti-LAG-3 works at 2 spots to activate those T cells, to see the tumor and kill it and recognize it as an enemy, not a friend. So yes, 2 checkpoints on the exhausted T cells, and we're reinvigorating those T cells to recognize tumor and kill it. Weren't sure that we'd see such an improvement, a 25% reduction, because it's still similar sort of checkpoint inhibitor mechanism of action. However, we have to remember the immune system is quite complicated, and for every checkpoint, there are some slightly different pathways they may be involved with. And also LAG-3 is expressed on the T cell quite late in its exhaustion. So PD-1, it is expressed before LAG-3. So it is slightly different. So yeah, that's the mechanism. Where does this fit in with the paradigm? I suspect, the other great thing about this combination, we all know about the anti-CTLA-4, anti-PD-1 checkpoint inhibitor combination. So that's ipilimumab and nivolumab for melanoma. That's quite toxic. We have a high rate of grade 3-4 toxicities for that combination. Now, this combination was not very toxic compared to nivolumab alone. It was quite stunning, actually. As a trialist, you know, as a medical oncologist, you get a feel of a drug. I did not, when I was putting patients on this trial, and I've also put a lot of patients on the Nivo-LAG-3 combination outside of this trial on a separate sort of phase 1 and 2 trial, I could not feel any difference with this combo compared with Nivo alone. So there is a slight increase in toxicities compared with Nivo alone. To give you an example, the grade 3-4 toxicities were 18.9% for the LAG-3 Nivo combo, but they were only 9.7% with the Nivo alone in this trial. I could not feel that difference. It didn't feel like that different when we were using the drugs, mainly because a lot of the grade 3-4 were also lab abnormalities. When you compare that with Ipi-Nivo grade 3-4 toxicities is 55%. So you're going 55% down to 19% for Nivo-LAG-3, down to around 10% for Nivo alone, grade 3-4 toxicities.
Yeah, that's great news. So is it unexpected toxicity, or again, is it just the same?
Same. Same, no unexpected. There was a theory that anti-LAG-3 could cause myocarditis, but we actually did not see that it increased the rate of myocarditis in this phase 3 trial. We were doing troponins all the time, and if you do troponins all the time, you'll see rises in troponin even on Nivo alone. So yes, this did not pan out to be a major limiting toxicity with this combination, which is great.
That's a good tip, because we've just added troponins onto our, standard set of bloods.
Yeah.
First few months now with the IO, we weren't doing that before.
I wouldn't do them because you get a lot of furphies. There's some cross-reactivity, and we would do it if patients have symptoms or we're concerned, because you'll end up chasing your tail.
Really?
Yeah.
Okay.
Yeah. And a lot of it's asymptomatic. And a few patients who did get a troponin rise in this trial that I was looking after, in fact, many did, but the ones that were real myocarditis had issues, symptoms, either edema. Yeah. So we don't do it routinely unless patients have symptoms or we're concerned. Yeah.
Some of the cardio-oncology guidelines are recommending that, but maybe that's cardiologist driven.
Yeah, it's interesting. To be fair, were they specifying the type of troponin test to do? Because that's another issue that's been discussed.
No, I don't think they do. They just refer to doing troponins, especially in this couple of months.
Yeah, to be honest, I can't recall which troponin it was, but there's one that's a little more sensitive. Certainly in melanoma, we don't routinely do troponin due to our experience of picking up a lot of false negatives. Yeah.
It's really good to know. All right, so LAG-3, really interesting. And, of course, there'll be trials bringing it into earlier lines of treatment.
So in the same ASCO 2021, we saw neoadjuvant combination of nivolumab and relatlimab. So it was nice to have that together. So in melanoma, I think we've discussed this before, neoadjuvant therapy, we don't use it to downsize or anatomical preservation, like, for example, in breast or esophageal or gastric cancer. We do use neoadjuvant therapy because we found that we get a very high pathological response rate with immunotherapy, particularly nivolumab, ipilimumab, or PD-1 CTLA-4 combo. In fact, 75% of patients with measurable stage 3 melanoma have a pathological response, and any pathological response is correlated with a flatlining of the relapse-free survival. And so we're not talking just complete pathological responses. In immunotherapy, a partial pathological response, a near complete, or a complete pathological response result in the same flatlining of the relapse-free survival, meaning virtually no one recurs. Less than 5% of people recur in time. Now, we did a new checkpoint inhibitor combination, the relatlimab, LAG-3 and Nivo, and we saw amazingly any pathological response. It was only 29 evaluable patients, a small study, any pathological response in 73% of patients. In this cohort, 80% of them would be BRAF wild type, so it's probably skewed towards the NRAS, NF1, so possibly more of the high tumour mutation burden tumours, but any path response rate, 73% in that combination. So it's seeming similar to Nivo-Ipi, but never compared head to head. So we have to be careful. So good. Another checkpoint inhibitor on the block and seemingly less toxic and effective.
Yeah,
and so that's where we're at.
There's grade 3-4 events lower than you would have expected with Ipi-Nivo combo.
So 55% for Ipi-Nivo combo and 20% for Nivo-Rela combo in the phase 3 trial.
Fantastic.
Yeah. So Craig, just as a side, we're now using the neoadjuvant platform. We've written white papers in Lancet Oncology. We've got the pathological paper in Annals of Oncology. And we are now using this platform for drug development because we've benchmarked response rates, path response rates, and then we use novel drug therapies where we've got the tox. So we've done the first phase 1A, and we go straight into neoadjuvant to look at the path response rate, benchmark it back to the drugs we know, and decide go, no-go decisions using that. So we don't use it to downsize tumour. We do it to develop drugs, but we do it because we think immunotherapy may be more effective given neoadjuvantly. We're going to be opening the phase 3 trial this year across Australia of adjuvant versus neoadjuvant. We also think patients love it. It's so much nicer as a patient to get your neoadjuvant and get your path response and know that you're not going to recur practically. Whereas in the adjuvant setting, as we know, you just got this rock on your shoulders. Am I going to recur? Every scan, am I going to recur? Am I going to recur? Got my adjuvant therapy, but am I cured? So this is the other great thing about neoadjuvant.
Yeah, fantastic. Reference my earlier comment about being the poster child. And, of course, neoadjuvant's really coming to the forefront in a number of tumours. Breast, bladder, rectal cancer, pancreas, gastric. I mean, I think that's really, again, the future of medical oncology, isn't it? So I know that there was a couple of interesting papers with long-term data. So, again, this is interesting for people who do melanoma, and some of the statistics now on those long-term survival is, again, holding up and really impressive.
It sure is. It's really impressive. So just quick note on this, and that's first of all the Checkmate 067 study, and that's nivolumab combined with ipilimumab versus Ipi, and nivolumab alone versus Ipi. It was a triple arm study. And so we saw in fact, 7.5 year overall survival. What's really neat, so I'm going to tell you those results. So we knew the 5-year overall survival for the combo Nivo-Ipi, so 2 checkpoints, was 52%, 44% for Nivo alone, and 26% for Ipi alone. We're now seeing 49%, 42%, and 23%. So that's highly censored, that part of the curve. So we're seeing just a few decrements in the percentage points, but really holding its own at 50% really for the combination, and that 40 to 45% mark for the Nivo alone, it's 42%. So that's good. It's flatlining and it's pretty much staying flat. But what's remarkable, and we don't think about this, well, we now are in medical oncology, for solid tumours, when you've got advanced cancer, you don't think about cure generally, except if it's a germ cell tumour. Now in melanoma, we think of cure. So for the first time ever, we presented a melanoma-specific survival curve. Because when you're getting out to 6.5 years and when we get to 10 years, you're going to have competing risks for death. Patients get old, they die of strokes, heart attacks, and other things. So to understand the pure activity of the drug in preventing melanoma death, we've now got to start doing, rather than overall survival, melanoma-specific survival, because of the nature of the change in how we're treating the disease. We are going for cure. We're not going for another extra year or an extra 2 years. So that was really fascinating that for the first time we actually had to present the melanoma-specific survival, because there's competing risks of death because patients are living and surviving.
So I noticed the BRAF mutant patients did really well as well. So just as a note to the audience, so if you have a BRAF mutant patient, because of this long-term survival, are you favouring giving Ipi-Nivo if possible rather than BRAF inhibitors? I mean, that's one of those.
So in the field of melanoma, we have data, a lot of circumstantial data from translational studies that show if you give the BRAF and MEK first and treat to progression, the tumour microenvironment is not favourable for immunotherapy. So you have a very much lower response rate and survival when it's given second line, but it's mainly the translational data that's driving that. We'll be talking about the ABC brain trial in a minute, but in that trial, as an aside, the patients who had had prior BRAF and MEK inhibitor, of which there were only 8, of the 8 patients that got prior BRAF and MEK and then went on to have ipi-nivo, only 2 responded.
Right.
So that was basically 25%. So 2 of 8. Whereas if you had it up front, then we got the response rate of 59% in the brain. So we went from only 2 in 8 of responding in the brain with ipi-nivo if you had BRAF MEK first, whereas if you were fresh first line, you had a 59% response rate. So, and we've seen that again and again in other data sets now subsequent to that. So that's just the first point about BRAF MEK. So in general, in melanoma, we like to use IO first. Then your question is, what do you use, doublet or single agent? So do you use CTLA-4 combined with PD-1 or PD-1 alone? And one of the factors that sways towards the combination, besides brain mets, they always equal ipi-nivo if patients can tolerate it, is the BRAF mutation. So young patients with the V600E mutation, they get a greater benefit by adding CTLA-4 compared with BRAF wild type patients in general.
So therefore, in your everyday, someone's not eligible for trial for whatever reason, so you would favour using ipi-nivo for the poor prognosis patients?
Definitely.
And the better prognosis patients, if they weren't up for ipi-nivo, you would give them single agent?
Anti-PD-1. Regrettably, in Australia, we have the PBS rules, and we're not allowed to make a choice up front and then go to the other. So, for example, if you saw a patient who was borderline sort of fit for combination, had lung mets and maybe a few lymph nodes and a few subcutaneous metastases, and you say, okay, I'm going to go with PD-1 alone. If they progress, we're not able to give them the combination. Now, that's the other data that we've presented previous years and again in another trial at ASCO 2021. But in previous years, we've shown in retrospective studies, it's just recently published in Lancet Oncology, Inesh Silva, who was a fellow with us and is now has joined us doing non-melanoma skin cancer. We published an international collaboration and we showed that combination CTLA-4 and PD-1 after progression on PD-1 had a higher response rate and a higher progression-free survival compared with ipi alone, CTLA-4 alone. So we're not allowed to do that in Australia. We can't go PD-1 and then the combination, regrettably. So you have to make your decision up front. So you have to have a lot of reasons not to give CTLA-4 to go with PD-1 alone because you're using up an option for patients. So in the end, what we do is we tend to go IO first if you're BRAF mutant. And then in choosing your IO, whether you're BRAF wild type or BRAF mutant, brain metastases, poor prognosis, high LDH, BRAF mutation are all relative indications for the combination. But of course, you then have to look at what are the support structures for toxicity, what's the socioeconomic issues for the patient, visiting, keeping in touch, and their comorbidities. But yeah, that's how we do it.
And so the BRAF inhibitors are really upfront or reserved for obviously the BRAF mutant patients, but those who are really not going to tolerate the IO, there's a contraindication.
Yeah.
Okay, fantastic. Great information. So, and then there's the ABC trial. I know you want to mention some first author on this paper called Georgina.
So I'm so proud of what we've done in Australia because this is an Australian study.
We're proud of you, Georgina.
Thank you. But I'm just such a proud Australian, and I just think my colleagues in the field are fabulous. So this is an Australian study. It was the first study in brain mets of immuno-oncology. And we randomized patients to 2 cohorts, either ipi-nivo versus nivo, with measurable asymptomatic brain metastases. There was a third cohort, cohort C, which was just people with symptoms or people with leptomeningeal disease, and they just got Nivo alone. They did very poorly. But the main point is the Ipi-Nivo plus versus the nivolumab. And what we saw was a very high intracranial response rate with the Ipi-Nivo combination. So in all patients in that Ipi-Nivo combination, it was 51% intracranial response rate. If you took out the people who'd got prior BRAF and MEK inhibitors, it was 59% intracranial response rate. And for nivolumab, it was 20%. What was really interesting is that a subsequent trial, a sponsored trial by BMS in the US, I think they had over 70 sites, showed exactly the same results as us. That was single-arm trial of just Ipi-Nivo, in that their intracranial response rate, I think, was 56, ours is 59, and their progression-free survival at 6 months was exactly the same as ours. Theirs was 69%. Our progression-free survival I'll give you the overall survival. The overall survival at 12 months was 63%, and the overall survival at 5 years is 51%. That's all comers, not even the one, that's including the ones that got prior BRAF and MEK. So pretty amazing.
People with brain metastases, right?
Yeah. So absolutely incredible results there. What was really, really assuring is that the subsequent US study with around 70 patients just getting Ipi-Nivo, exactly the same results in terms of response rate in the brain and the intracranial progression-free survival. So that's the standard.
So these patients, do they have radiotherapy now, or only if they don't respond? Or
so it's an interesting question. It's in Europe, I believe they don't use as much Ipi-Nivo. It's not approved in some countries across Europe, like Italy, for instance. So they use PD-1 monotherapy a lot more, or don't have access to the combination. So when patients are getting single-agent PD-1 in Europe, for example, they will use stereotactic radiosurgery in combination. In Australia, we tend to start with Ipi-Nivo, watch patients carefully, do a 6-week MRI, and just check whether they're stable or responding, and only use stereotactic radiosurgery or even surgery to rescue any metastases that aren't responding. We're doing so much more aggressive management of brain metastases than we ever did. We resect a lot more. We give stereotactic radiosurgery a lot more. And our patients are living, even patients where they have progression in the brain, are living 5-6 years, and some succumbing then, but they're just doing brilliantly. It is fantastic. The majority of the patients alive at 5 years on the ABC study on the Ipi-Nivo arm are complete responders in the brain.
And just an aside, I feel always when we see changes like this, I often think back to the patients that were alive with this disease before we had these tools. So, you think about all the people who just had rapid.
Terrible.
It's always that. Yeah.
On that point, though, I do want to stress 30% of melanoma patients do not respond to any of these drugs and just die within 9 months. And that is where we're working in our lab. We've got a large translational lab looking at how we can best manage those patients and what drugs we need to come up with. But if we can solve that problem, I think we could solve a lot for immunotherapy resistance across oncology.
Yeah, great. Well, that probably segues into the last paper we wanted to cover, which is a brand new treatment, which, looking, they used to say 30% of people don't respond. So what do we do? And here's potentially something, lifileucel.
Yes. So lifileucel, we're actually working with this company to see if we can utilize their structure to do this very easily in Australia. So let me go through lifileucel. Lifileucel is basically an adoptive T-cell therapy. So what they do is you resect your cancer, some of the melanoma, just a sample. You then grow that cancer to try and extract the TILs, the T cells from that tumor. And that takes around 22 days to grow out the T cells and form an infusion product of T cells, which are specific to that patient's tumor. In the meantime, while you're doing that, in the 22 days to form this infusion product from the tumour, you then give the patient non-myeloablative lymphodepletion, and then you reinfuse that TIL from that tumour, along with IL-2, which is a cytokine which stimulates T cells and decreases the T regulatory cells. So in that study, they took 66 patients who'd progress on anti-PD-1 inhibitors and went through this process. Interestingly, 41% of those patients had a high LDH, so they're not great players. In a typical first-line trial, by the way, you will find about 35% of patients have an elevated LDH. Of those 66 patients, 50 had a reduction in their tumour burden. 24 actually responded, so that's a 36% response rate. And of all those that responded, only 8 have progressed. So it's basically a 36% response rate having progressed on PD-1 therapy. Does that make sense, what I've explained?
Yeah, absolutely. The treatment sounds really complex. It's obviously not going to be something done everywhere, and people can click on the link to see the details, but it involves 5 days of cyclofludarabine, then the infusion back, interleukin-2. So, it sounds pretty tough treatment.
So just on that, this used to be the treatment for melanoma 20, 30 years ago, but done in a different way. What this company have done is they've made that TIL infusion product sort of more commercially and ramped it up. That's the difference. But all that lymphodepletion and then the IL-2 infusion with the TILs, yeah, that's like the old-fashioned way. Yeah.
I guess it highlights too, we need to keep being advocate for trials. We need, you mentioned the 33% of people with melanoma who don't respond, so we've still got a way to go. And yeah, it was actually a really exciting ASCO, maybe not anything that immediately changes practice, but gives us some important clues about where to next. And it'll be melanoma leading the way, but I imagine the LAG-3 will be
absolutely
other tumours as well.
We've already done triple therapy phase 1 trials of various checkpoints and other drugs that are looking very interesting. But no.
Fantastic. So, Georgina, thank you.
Thank you.
I hope people could hear the passion in your voice when you're going through all this data. They don't have the benefit of the vision, but, you're clearly passionate about it. It's fantastic. It's a real pleasure and honour to have you talk to our audience, international key opinion leader. You're a great role model for all medical oncologists, but in particular, young women in Australia. So thank you for coming on. Well, hopefully it won't be the last time. And again, thanks for your time and sharing your expertise.
Well, thank you so much, Craig. You hit the nail on the head. I do love talking about this stuff. So thank you so much for asking me all those great questions.
Oh, my pleasure. Fantastic. Thank you so much.
Thanks. Bye.
Bye.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.